Welcome to Trib Talk, a production of the Salt Lake Tribune. I'm Nate Carlisle, a reporter at the Salt Lake Tribune. I've been covering the pandemic now for going on 5 months. Today we're talking with two medical professionals, one an emergency room doctor, the other Utah State medical examiner. We're going to be talking about how coronavirus kills, what it's doing to patients right now, what medical professionals are seeing in Utah right now, and hopefully a little bit about how to further prevent the infections and deaths that are occurring in Utah. Let me start by introducing Dr. Marion Bishop. She's an emergency room physician at Cache Valley Hospital in Logan, Brigham City Community Hospital in Brigham City, and then in Evanston, Wyoming, and I'm blanking on the name of that hospital right now, but thank you, Dr. Bishop.
Yeah, Evanston Regional.
Okay, there we go. And then also Dr. Erik Christensen, the Utah State medical examiner. Dr. I guess we didn't all get that joke, but usually the state medical examiners, for us reporters run into them, it's usually because they're testifying in a homicide trial. Yeah. So let's go ahead and start with Dr. Bishop. If you haven't read it already, Dr. Bishop has been blogging a little bit about what she's been encountering these last few weeks and months in her emergency rooms. We put a link to her blog on our webpage. It's on the Salt Lake Tribune website for this Trib Talk. Dr. Bishop, go ahead and tell us a little bit about what you're seeing in the emergency rooms.
Well, you know, in the early days of the pandemic, I was ready for us to be in the same way that, you know, New York City was. I lived there for a number of years and still have friends there. And so had this anticipatory kind of sense of what was going to come. But actually, it's been a slower building wave. And it kind of has taken us a little while to learn on the ground what COVID looks like. On any given shift, there's a range of patients that I might see. On the one hand, there are folks who are just kind of well but worried and would like to be tested. Kind of that the next grade is probably someone who has recently been tested and just feeling poorly. They check in, they might need some support, they might need some guidance. Then there's somebody who has recently tested positive who is struggling, you know, maybe coughing so much that they can't breathe, maybe having a lot of tightness and heaviness in their chest and finding it hard to breathe, maybe having low oxygen levels. And, you know, those folks we need to do more with. They might get a chest x-ray, we'll draw blood work, we'll try and learn a little bit more about how we can support them and help them. And then on the far end are people who are critically ill. Who have kind of progressed from mild to, you know, from asymptomatic COVID to mild COVID to moderate COVID to, you know, being very near death. And for those people, it's a question about, can we sustain them with modalities like high flow oxygen, or do we need to intubate them? So that whole, and I don't see all of those patients every shift, but I see some representation of that range most of the time I go to work. Okay.
Dr. Christensen, let me ask you kind of a big picture question here. As of right now, the Utah State Health Department is reporting slightly more than 300 deaths in Utah from COVID-19. Mm-hmm. And there's been a debate about just how many people it's killing. Do you think the number right now reported by the State Health Department is accurate?
Yes. Yeah, I mean, there's been a lot of discussion about that, what counts as a COVID death. And I've had multiple calls and other discussions with people thinking and asking, you know, doctors are being pressured to put COVID on there, even if it's not really COVID and things like that. And, you know, that's not what we're seeing, first of all. And I don't really understand that would be otherwise, but the way we're structured in Utah, these cases are every death related to COVID is reported to the Office of the Medical Examiner under our authorizing statute, which puts threats to public health under our jurisdiction. We don't bring all of them in for examination. You know, if someone has been to a hospital, been diagnosed with COVID, has a typical course of, you know, they might end up in the ICU and ultimately dies of their illness. Those cases are not coming to us for examination or autopsy, but we're still reporting them. We still investigate them. We follow up on the death certificate to see what's put on the death certificate to make sure that it matches the clinical course that's been described, and to, you know, make sure that the data that are being reported are accurate. So I think the numbers are very reliable.
That brings me to something I want to show the viewers, Dr. Christensen, and Sara, if you can please put this on the screen. Death certificates aren't typically public in Utah, but one has been entered into the public record, and I've just clipped an excerpt of it here where it describes the cause of death here. And so it looks like here there's this person had multiple symptoms or mortalities. And then you see COVID-19 kind of listed in the bottom right corner there. Can you walk us through this, Dr. Christensen? And what is this death certificate trying to articulate here?
Sure. So a death certificate is it's the certifying physician's opinion as to what led to this person's death. And as you can see there is a top line where it says severe sepsis with septic shock, followed by due to, meaning the severe sepsis with septic shock is due to acute hypoxemic respiratory failure, which is then also due to pneumonia due to COVID-19. So that's a sequential series of conditions. The immediate cause of death, we would call that top line, was that there was, septic shock. And this certifier believed that that was due to respiratory failure, which was due to COVID-19 pneumonia. And so that's that sequence of events. Sometimes death certificates get used as a kind of a laundry list of all the problems a person has, but they're supposed to be sequentially linked, like, the way the due to or as a consequence of verbiage suggests there. And so that's the only real kind of cleaning up we've had to do so far on death certificates is, changing them sometimes from a laundry list to a more, taking those things that are in the list and putting them in an order that makes sense in terms of their cause. But as it says there, the medical examiner was contacted. We hear about all of these. Autopsy was not performed, and the death was certified as natural. These are all natural deaths, as opposed to many of the types that we examine in our office. Okay.
And walk me through this a little bit, because as you said, there's been some debate about, whether COVID-19 really kills these folks or if it's underlying conditions like diabetes or emphysema or what have you. I mean,
sure.
Have you guys been using this to determine, what actually kills people? Would you say you've been using the same procedure you've used to determine and categorize any type of mortality over the decades?
Yeah, pretty much. I mean, so the types of deaths that come to us, most typically the kind of thing, for example, somebody that dies in a hospital that doesn't come to us for examination would be somebody who suffers, lethal blunt trauma as a result of a motor vehicle collision, for example. If they've survived in the hospital for 5 days, the trauma surgeon or the attending on the trauma service understands why they're dead. From their injuries, we allow them to certify that individual's cause of death without coming to see us. Even though they fall under our jurisdiction, we still have a case file. We still investigate the circumstances of the accident to make sure that what we were told, is what is. But it's very similar to that. And, cause of death determinations are something, that's, I guess I would say, our bread and butter. That's the primary thing that people rely on us for, is to make an accurate determination of the cause of death.
Have you had any families argue with you about whether COVID-19 should or should not be listed as a cause of death?
Not with me directly. I did get a message referred to us a while ago, and have not been able to connect with that individual. Somebody whose death, who they thought the death was not related to coronavirus. The medical information that we had from the records made it pretty clear that it was. But and so we've left that one as it was certified by the attending, barring further input. We have on a few occasions actually removed coronavirus from a death certificate, where we've had circumstances and where the attending put it on there simply because the person tested positive, but really never had any symptoms that could be referable to coronavirus, and so we've removed that in a few cases. But for the most part, the deaths that are coming here for review have been accurately certified.
Any indication why a family wouldn't want coronavirus or COVID-19 on a death certificate, or listed as cause?
No idea. No.
Okay. Let me go ahead, Dr. Bishop.
Well, I just was going to say, looking at the report, that's also the spectrum of illness I outlaid for you in your first question. There are folks who have few symptoms. There are folks who begin to cough, and about 18 days before death, someone might present in my emergency room with pneumonia. About 12 days before death, they might present with pneumonia and in respiratory failure, needing assistance, needing some kind of machinery to help them breathe. And several days after that, they may progress to full system organ failure, which is the fancy name for that is sepsis. So this is very elegantly outlines, how that disease progresses. And, we meet people wherever they're at with it in the emergency room.
Okay. That brings me to something I wanted to ask you, Dr. Bishop and Dr. Christensen. Feel free to weigh in on this too. I've been told previously that if you show up in an emergency room, you as a patient may be doing it wrong, that maybe you've got an ailment you should have had a primary physician help you treat or take care of. I mean, does that apply to coronavirus? Is this something we can manage in consultation with if we contract it? Manage in consultation with our primary physicians? And is there a way to manage our symptoms effectively? Or is this something that if you've got it, you could just wind up in the emergency room no matter what?
I think both things are true. ER doctors really pride themselves on taking care of anyone at any time. And my colleagues and I are happy to step up and to show up for someone in any circumstance. And often people don't have anywhere to go, and they should know that emergency rooms in Utah are open and happy to take care of them. The other thing is also true, though. If you have a good relationship with a primary care doctor and you have an outpatient test and your symptoms are mild to moderate at home, you can probably manage pretty well in consultation with your physician's office. And you can even call them and say, do I need to go to the ER now? Or at what point do I need to go to the ER? At what point do symptoms become concerning enough that I need more intervention? And a good primary care doc can answer those questions for you. And then we are happy to take care of you when you come in. That's our job. And we'll meet you at whatever point you are at in that illness.
Yes. And of course, we should clarify, this assumes you have a primary care physician, which a lot of people don't. And we could spend a long time on that too. But for those of us that are fortunate enough to have primary care physicians, thank you for clarifying that. Dr. Bishop, I mentioned the blog post. You've written multiple posts actually kind of related to what you're seeing in the hospitals. And again, we've linked to that on the Salt Lake Tribune webpage with this video chat. I want to talk specifically about how you're keeping yourself safe and your family safe. So let's talk about you for a moment rather than your patients. But can you just kind of lay that out for us, please?
Well, I think for anyone in healthcare right now, it's a little bit daunting. And the thing that we got in the Intermountain West by kind of the school closures and whatever else was a few months to prepare, before we started seeing patients. And that included hospital systems getting adequate PPE. It included learning how to wear it. It included, they're actually very elaborate donning and doffing procedures. The time you're at the most risk of inoculating yourself with whatever is on your apparel is when you take it off. And so there are ways you have to learn how to wear it. You have to learn how to wear it appropriately. I've been grateful that my hospital systems have worked really hard to make sure that we're protected. But when I go to work, I usually, especially when taking care of COVID patients, I'll wear an N95 mask, which fits so tightly to your face that there's a seal. It can actually, it leaves marks, it can cut holes, it's uncomfortable. I'll wear that depending on how many patients we're seeing for most of a shift, or it depends on the hospital and it depends on the day, but for a significant amount of time. Often I'll cover it with just a regular paper surgical mask because that helps the N95, it kind of preserves the longevity. The N95 will last a little longer and I can use it more. I have to cover my hair. I have to wear goggles or glasses. I usually just wear my own glasses. And then often too, we usually will wear a face shield. Then I'm in scrubs. Most of us try and cover our arms. It's gotten a little harder for me to do that as it's hot. Anyway, and gloves. I probably change gloves 30 to 50 times a shift because after every patient, I have to take them off and put on another set so that I don't contaminate the patient. Similarly with my face shield. And it's not just me. Like, I'm not special. This isn't because I'm like an ER doctor. This is nurses, respiratory therapists, phlebotomists, x-ray technicians. There are rank and file people up and down the Wasatch Front, like going through this rigmarole every day on behalf of people who have COVID. Like, I'm just proud to work with all of them. And then the opposite thing happens when I leave. I take off my dirty scrubs. There's a facility at my hospital where I can shower. I shower, I put on a set of clean clothes. Then I have to walk back through the dirty hospital in those clean clothes. So when I get home, and this is probably because I have 2 small children and I'm a little bit nervous, and also because it gives me something to do. I undress in the garage. I take off all my scrubs. I put them in a bag. I put the bag up on a high shelf. I take off my shoes. My shoes don't enter the house. I take that bag, I don't put my shoes back on until I go back to the hospital again. I take that bag of scrubs down when I go to work the next time and return it to the hospital. And then I wrap myself in this kind of big fluffy bathrobe and dart through the backyard, kind of in through a door, and take a second shower. And my children know not to, not to touch me or interact with me until I've gone through that whole process. I have a neighbor who's a respiratory therapist at a neighboring hospital. She does the same thing. This is, we all have our kind of our routines to try and not bring this home to our families. And
can you just clarify, are you seeing a COVID-19 patient or multiple patients on every shift at this point?
I would say it depends on the hospital. One hospital less, one hospital medium, one hospital medium plus. And I'm certainly doing testing on every shift. I'm certainly seeing mild cases with reassurance on every shift. And not every shift do I see someone who's like on the far end of what we talked with Dr. Christensen about. At COVID receiving centers like the University of Utah and IHC, they are seeing more of those kinds of patients. But part of what I am at risk for, and every, doctors, nurses, respiratory therapists, phlebotomists, what we all are at risk for are patients who come to the ER with different sets of symptoms. For example, having been involved in a motor vehicle accident, having been involved in some kind of trauma. I've done this on more than one occasion. Worked somebody up for trauma, done a CAT scan of their chest looking for broken ribs, pneumothoraxes, back fractures, and discovered bilateral pneumonia that's consistent with what COVID looks like. And then having to go through the whole rigmarole to swab them, someone that felt well enough to be out in whatever activity they were doing, but still is sick. And that's a scary thing. You only have to do that once or twice to remember to wear your PPE when you see patients. So
you can see the pneumonia on the chest scans?
Yes. Yes.
Okay.
COVID pneumonia has a kind of classic appearance. It's you can see it on chest x-ray. You can also see it on CT scan. There are other pneumonias that look like COVID does, but when you see it, you think of the 2 or 3 things. There are 2 or 3 kinds of pneumonia that look this way on chest x-ray. The one that's most common at this time of year in this location is COVID. And radiologists will usually write a report that says it's a bilateral pneumonia. It's a pneumonia that's in both lungs. It's a pneumonia that's in the bottom of the lungs, which is part of why you get that deep, awful cough. And radiologists will, describe a bilateral, a 2-lung pneumonia process, and often they will say, suggestive of COVID pneumonia.
Dr. Christensen, what about you? Have you and your staff had to take any extra precautions, or are you doing anything different due to COVID-19?
Yeah, so we early on started having our investigators at any death scene that they responded to ask questions about symptom history, and if people were having any symptoms, that would be considered flu-like, and as well as, significant travel or, exposure to known cases, all of those things. And any case that came to us with that sort of symptom constellation, we handle in our isolation room, where everybody doing those cases is mostly wearing powered respirators to keep, give you fresh air the whole time you're working. And so we've all gotten very good at wearing those now and using them and working in them and doing them in that room. There are a number of cases. We also, early on, and we expected this would be the case just because we see this occasionally with like seasonal influenza, where someone has the illness but doesn't realize how sick they are. or minimizes the symptoms, well, it's just a cold or, whatever, and they end up dying at their residence before they ever get seen or tested. And so we expected we would see cases like that. It's kind of taken a while for that to pick up, but we're definitely seeing more and more of those. July, quite a few of them. And so for all of our cases, unlike the patients that show up in a hospital or in a clinic or wherever they show up, our patients are no longer breathing. They're not coughing. They're not doing the things that are, the high risk activities for sharing this virus in the environment. And so, for us, the highest risk activity is anything that we do that aerosolizes things. And for us, primarily, that's opening the head. So we minimize that. Sometimes we avoid that altogether, depending on how risky we feel the case is, at least until we have the testing results back. We test everybody that comes through here. We do see a number of cases of, people that are just, completely incidentally going about their business, died in a car crash, died by suicide, died by whatever other means, that turn out to be positive, when we test them. We've had a number of cases positive that we've tested and embalmed people even. We've had people that have been decomposed for a period of time who have still tested positive. And so, it's definitely out there. And, we're seeing it at a higher prevalence in our just routine ME population than we did previously. But we're also seeing of all the deaths in Utah so far, I think we've had, the last time I looked was about a week ago, about 7 to 8% of them were diagnosed here. So people that came here didn't have a diagnosis until we saw them. So we were primarily responsible for diagnosing and certifying them. That's a pretty modest number. We can certainly deal with that kind, but our overall sort of regular caseload is up a lot too, and that's put a lot of strain on our staff. So
a few things. So first of all, just to clarify, if they die of, again, that car crash or suicide and test positive, they're not recorded as a COVID death.
No.
It's just the positive results just reported to the health department for their infection numbers,
right.
Correct?
Right. It is, yeah. It's reported as a positive, as a diagnosed case, but it is not reported as a COVID death.
Okay. And then did I hear you say that your total number of the cases coming into your office, i.e. deaths in Utah as a whole, is up right now? And I know, is that just a function of how Utah keeps adding people, or is there something else at play here?
I don't know. Haven't had time to actually look at where those numbers are coming from. There's no question that there are a lot, even excluding all the additional COVID work we're doing. Our workload's up probably 10 to 12% over a year ago. But I don't know where that's all coming from. Haven't had time.
When you say caseloads, does that mean 10 to 12% more deaths in Utah compared to a year ago? 10 to
12% more deaths that fall under our jurisdiction that are coming to us. So we, in a typical year of all the deaths that occur in the state, we examine anywhere between 15 and 18% of them. Those are the ones that fall under our jurisdiction according to the State Medical Examiners Act, which specifies what types of things we need to be involved in. That percentage or that number last year, for example, we examined 3,350 cases or so. We had jurisdiction in that many cases and did actual exams in about 3,000 of them. And that number is up pretty substantially. We're on pace right now to hit about 4,400, but probably about 500 of those will be COVID deaths just reported to us. But even without that, that is still a pretty dramatic increase in our overall workload.
We've all seen images of freezer trucks being used as temporary morgues in other states or cities. Is that going to happen here, Dr. Christensen? Does your office have space, or are the bodies piling up like that?
So I guess I would address that in a couple of ways. So if, most of what happened in, New York City, Detroit, and other places like that were having that kind of backlog, it was, cases that were not going to the medical examiner's office, cases that were just dying and needed to move through the usual postmortem process of going to whatever funeral home the family selected. But just that the funeral homes were so completely overwhelmed that they didn't have the ability to either store them in their own facilities or to, have them somewhere else in the hospital. Certainly didn't have storage capacity. Nursing homes didn't have storage capacity. And so we have worked, with the state emergency planners to, try and provide redundant redundancy, no, I don't think anybody has really maxed out their capacity at this point. We have had, just from our workload, we're definitely pushing the limits of what we can store locally. We do have additional refrigerated storage that we brought on early here at our office, just should we need that. Should hospitals not be able to pick up from us, then we have the ability to expand our storage capacity. We haven't needed to use that yet, but that may yet come. Just kind of depends on how the trend goes from here.
Okay. Can both of you talk to me about the trends you see related to COVID-19? I mean, rural versus urban, racial disparities, occupational trends. I mean, who are these folks that you're seeing contracting COVID-19 and Dr. Christensen's case dying from it generally?
In Cache Valley, we had a big outbreak at a meat processing plant. The community rallied and gave those folks a lot of support. There was some worry that there would be a lot of community spread from that, but it wasn't. I'm really grateful that we were able to contain that so far. And it's definitely true that I'm trying to think if I probably haven't seen enough cases to talk statistically, but what I can feel confident saying is that folks without a lot of support, folks who don't have a strong kind of family or friendship circle that can support them through this illness at home, have a really hard time. You're going to be sick. Like, even if you have a case that doesn't require you to come to the hospital, you're going to be sick, probably sicker than you've ever been for an extended period of time at home. And without enough money, without enough food, without family or community resources, it's hard to get well. And I've seen that multiple times.
Dr. Christensen, what about you? Any trends you can report at this time?
No, the numbers that are reported by the health department, on fatalities come from us. There's certainly, we've seen a high number of deaths associated with long-term care facilities. I think the most recent numbers that it's somewhere around 40%, somewhere in that, of the total numbers. We do see a lot of Hispanic individuals. There's been a lot of cases out of San Juan County has been reported. The numbers that are being reported, by the health department are reflected in what I'm seeing.
Okay. Let me ask you both. I mean, if you had complete control over the state and federal response, what would you be ordering or mandating or telling people to do to reduce the spread and mortality of this virus? Start with you, Dr. Bishop.
Oh, I would say simply, the simplest thing we can all do to help each other is to wear a mask. It's a nuisance. Dr. Christensen and I have both talked about the challenges of wearing them. It's not always pleasant. It's not always convenient. And it's not really something I do for me. It's something we do for each other. Masks were designed to hold things in. They're a little bit good at keeping things out, but they're excellent at holding things in. And I know there was some question about the efficacy of mask wearing, but I think mostly that's been settled, including by that great study out of BYU, that looked at Salt Lake City after they had the mask mandate. And I think sometimes wearing masks gets tied to, well, I want my freedom and I want to be able to do whatever I want. But to me, the irony, I guess a couple of points, the more of us who are willing to wear masks, the easier it is for things to stay open, the easier it is for the economy to function because people aren't getting sick. And the other thing is that sometimes I feel if I could just take some folks to work with me, if I could show them even what moderate COVID looks like if you could do something in 10 seconds that would protect your family from that, there's kind of no question that you would do it. I get maybe one other thing, part of what's happened in trying to protect everyone is that the illness of COVID is kind of happening in hiding. It's happening in quarantined homes. It's happening in hospitals. Unless you're in healthcare, you don't really see it. But it's worth seeing, and I think thoughtful people with a little bit of education about what it's like to be sick with this disease, mask wearing becomes less of a question.
And you, Dr. Christensen?
So, I mean, I think wearing a mask is a good idea. I mean, like was said, the studies there, support that that's a prudent thing to do. I guess the one thing, this is sort of unique to our population of patients, but if you have it, if you've been diagnosed, and we've seen a number of cases like this where someone was diagnosed and they went home to quarantine and got sicker, and they're like, no, I can just take care of this. If you're getting sicker, go get seen again. So,
okay.
Absolutely. We don't want people to suffer at home. If you need help, please come in.
Okay. Well, we are just about out of time. One thing I want to circle back real quickly, Dr. Christensen. So if someone is dying at home from COVID-19, you're confident that's being adequately investigated and documented? We're not missing people who are dying at home in Utah at this point?
No, we've got a multifactorial, multi-layered process in place for deaths to be reported to us. The Division of Epidemiology folks send me a list of deaths that they're aware of and people that have tested positive. I compare those to the things that we have. I can look them up and find out who certified them. We've got vital records keeping track of any death that has COVID added to it as a part of the cause. If it hasn't already been referred to us, they refer it to us. Anybody that gets on to sign a death certificate, there's a notice that says this needs to be reported to the medical examiner. So I don't think we're missing very many people. So.
All right. Well, we need to end there. Thank you both very much. Emergency room physician Marion Bishop and State Medical Examiner Dr. Erik Christensen. Thank you both. Please stay healthy. This has been Trib Talk, a production of the Salt Lake Tribune. Please watch us again. Watch for us on sltrib.com. And everyone stay healthy.
Thank you.
Thanks.